Right, so question number 2. A 55-year-old patient with a history of hypertension and diabetes presents to the clinic with symptoms of fatigue, decreased urine output, and swelling in the leg. This is leg. On examination, the patient's blood pressure is elevated and there is bilateral pedal edema. Okay, laboratory tests reveal elevated serum creatinine. The physician suspects renal failure and wants to differentiate between acute and chronic. Which of the following would be most helpful for the differentiation? Now, pause and then tell me. Right. So, I think, and the answer is actually ultrasound. Now, why is that? Because renal ultrasound is the gold standard modality to distinguish acute kidney injury from chronic. Bilateral small shrunken echogenic kidneys will indicate irreversible long-standing parenchymal disease, which is chronic kidney, whereas in acute it will be an acute process, so it will be normal sized. This is a snapshot from first aid, in which you can see that the consequences of renal failure, which is usually chronic kidney disease, will be this mnemonic, and this is actually a high yield topic as well. Also, it's important to note that uremia, which is due to high serum urea, will present with pericarditis, encephalopathy, anorexia, and nausea. So this mnemonic is actually important to remember, right? Now, on to question number 3. A 42-year-old patient, history of IV drug use, presents with a chronic cough, night sweats, unintentional weight loss, and jaundice. So if he's an IV drug user, he has night sweats, unintentional weight loss, we're thinking maybe TB. And that's exactly that. A chest X-ray reveals apical infiltrate, sputum microscopy positive for acid-fast bacilli, so it is TB. The patient is suspected to have TB with hepatic involvement. What is the most appropriate initial management? So the answer is B. Initiate a 4-drug regimen for 6 months. Now, why is that correct? Is because active pulmonary tuberculosis confirmed by acid-fast bacilli is treated with a 6-month course. And this is a snapshot of Irfan Masood. So you will have an initial phase, the first, which is 2 months. So for 2 months, you will give 4 drugs ripe, and then you will continue for the next 4 months, 2 drugs, which is isoniazid and rifampin. Right? So the answer would be B. Now, going on to question number 4. A 55-year-old patient presents with painless hematuria, flank pain, and unintentional weight loss. Sorry about that. It was too thick. 55-year-old, painless hematuria, flank pain, and unintentional weight loss. Okay. A palpable mass is found in the left flank, and the imaging shows a solid renal mass, raising suspicion for renal cell carcinoma. What would be the appropriate next step in management? Pause. Right. So the answer is you will order a CT scan with IV contrast. Now, why would you not do a biopsy? It's because a renal biopsy is avoided due to the risk of tumor seeding. right? And would you do a CT scan with IV or without? We said with, because contrast helps us in the definitive staging and diagnostic modality for suspected renal cell carcinoma. It characterizes the vascularity of the solid mass and checks for local invasion. While without contrast, a CT scan cannot delineate the tumor margins. Right. Now, this is a snapshot of Irfan Masood in which you have the treatment for, or the diagnosis for renal cell carcinoma. It says that ultrasound is the best initial test. That's because you don't know if it's a simple renal cyst or it's a solid tumor. In our question, the doctor already had a suspicion of renal cell carcinoma. So that's why we're going for contrast enhanced CT scan. Right. Now on to the next question. A 60-year-old patient with a history of colorectal adenocarcinoma presents with fatigue, weakness, and unintentional weight loss. Labs show a decreased hemoglobin. Which investigation is most helpful in confirming the diagnosis and assessing the severity of his condition? Pause. Right. So the answer is colonoscopy. And that is because colonoscopy will allow direct visualization of the entire colon and provides the opportunity to take biopsies, which is required to definitely confirm a diagnosis of colorectal cancer. Now, we can do an occult blood test, but that will not confirm the diagnosis, but it's a useful screening tool. While CEA is a tumor marker that's usually used for monitoring recurrence. Right? Ultrasound is not routinely done, and CT abdomen at the moment is not being done. Now, on to the next question. A 60-year-old male with diabetes and hypertension has a routine checkup. His blood work reveals a serum creatinine of 2.5, which is higher than previous. He denies recent illness or changes in medication. What diagnosis could be suspected? Pause. So the right answer is chronic kidney disease. Why is that? It's because, and just let me take you back to the screenshot that I took of 1 minute. Right. So as you can see, a patient with chronic kidney disease usually has chronic has hypertension, diabetes, and congenital anomalies. Right? And in our patient, we also have diabetes and hypertension as well. But the major reason is that acute kidney injury or dehydration would not produce such a massive increase in creatinine, and they usually have an identifiable acute trigger. And also, they have a rapid onset with systemic symptoms. Right. While chronic kidney disease will not have systemic symptoms, the patient is perfectly fine, just a slight increase in creatinine. Right, on to the next question. A 55-year-old with uncontrolled diabetes is diagnosed with chronic kidney disease and develops secondary hyperparathyroidism due to progressive decline in kidney function. Which laboratory parameter would you expect to see elevated in the patient's blood work? Now, okay, pause. The answer actually is serum phosphorus. Now, why is that? Because in chronic kidney disease, failing kidneys cannot clear the phosphate properly, which leads to a hyperphosphatemia. High serum phosphorus will directly bind to the calcium, right? So you will have failing kidneys, which cannot excrete phosphorus. Phosphorus binds to calcium, causing a decrease in calcium, which causes an increase in PTH hormone. Now, here's a snapshot of first aid. Now, this is a very high yield topic. You have to remember that in primary hyperparathyroidism, the patient will have an increase in parathyroid due to an adenoma. It's an adenoma or hyperplasia, right? So patient will have hypercalcemia. Now, the symptoms of hypercalcemia are renal stones, polyuria, thrones. Patient will have bone pain, which is groans, abdominal pain, flank pain, which is kidney stones. And hypercalcemia also causes neuropsychiatric disturbances. So stones, thrones, bones, groans, and psychiatric overtones. While in secondary hyperparathyroidism, it's secondary, so it's secondary to something. So the patient has decrease in calcium or an increase in phosphorus, which is most commonly due to chronic kidney disease. So the patient will have hypocalcemia, hyperphosphatemia, and hyperparathyroidism. Tertiary hyperparathyroidism is refractory. It is usually end-stage renal disease, which causes tertiary hyperparathyroidism. Sorry. Now, question 8. A 40-year-old patient presents with sudden onset weakness and tingling in their legs days after a severe respiratory infection. Right, so the clue here is they had respiratory infection and now they have weakness and tingling in their legs. The examination reveals diminished reflexes and muscle weakness. The physician suspects Guillain-Barré syndrome, and which treatment option will be indicated? You can pause. The answer is intravenous immunoglobulin, because the treatment for Guillain-Barré syndrome is either plasmapheresis or intravenous immunoglobulin. This is a snapshot of Irfan Masood, and it says the same thing. That for Guillain-Barré, you will use plasmapheresis or intravenous immunoglobulin. Another diagnostic clue which is very important to remember is that Guillain-Barré will have albuminocytologic dissociation, in which the CSF protein is elevated, it's greater than 55, but there's no rise in the number of cells. Right. Now, question number 9. A 28-year-old female, so she's young, she's not old, weight loss, increased appetite, palpitation, sweating, and tremors. She appears anxious, her heart rate is fast, menstrual periods are irregular, and her eyes are slightly prominent, exophthalmos. This is also a keyword. The physician suspects hyperthyroidism. Which test is relevant to confirm the diagnosis? Pause. So we will do thyroid stimulating hormones. Thyroid ultrasound will not give us the correct answer because in hyperthyroidism, the patient will have increased levels of T4, T3 and decreased TSH. You can ask why not thyroid peroxidase antibodies? This is seen in Graves' disease as well as Hashimoto's, but it will not confirm our diagnosis. Because in Hashimoto's, in Graves' disease, it is usually a thyroid stimulating immunoglobulin that stimulates the TSH receptors. Right. So, next question. TPO antibodies help identify autoimmune origin, but they will not confirm functional hyperthyroidism. Right. A 24-year-old female presents to the clinic. Oh, one more question. Was the previous style of question, is this better for you guys? Or is this one? Do let me know. A 24-year-old female presents to the clinic with complaints of persistent low mood, lack of interest in activities, feeling of worthlessness, difficulty sleeping for the past few months, and they're affecting her daily life and work. She has no significant medical history, but she has a family history of depression. Suspects major depressive disorder. Plans to initiate a pharmacological treatment to help manage her symptoms. Which drug is most appropriate to initially prescribe for the patient's depression? Pause. Right, so the answer is SSRI. Now over here, they're actually telling you that the patient has depression, while it is also very important to learn this mnemonic SIGI caps. And over here, they're also telling you that the patient had the symptoms for a few months. So major depressive disorder is recurrent episodes that last greater than 2 weeks, which is characterized by greater than 5 out of the 9 diagnostic symptoms, which is SIGI caps: sleep disturbance, decreased interest, guilt, decreased energy, decreased concentration, appetite changes, psychomotor retardation, and suicidal ideation. So over here, the patient had low mood, 1, lack of interest, feeling worthlessness, difficulty sleeping. So 4. 1 is missing. But since they're already telling you that she has the family history, she is diagnosed with this, so that's why. But over here, according to this, it's only 4. Now, next question. A 2-year-old, okay, so very young child, brought to emergency department from falling from bed, landed on her outstretched hand, and is now complaining, outstretched hand, that's important, complaining of severe pain in the right elbow. There is obvious deformity and swelling around the elbow joint. The child is unable to move the elbow, and there is pain in passive movements. There is decreased sensation and weak pulse. What is the diagnosis? Pause. So the answer is fracture of the humerus with compartment system. Why is that? Because falling, usually in a child 2 to 7 years of age, falling on an outstretched hand means a supracondylar fracture. Like this. This is a screenshot from UWorld, which is the clinical features is fall onto an outstretched hand and the patient will have pain and swelling. Right, the treatment is usually long arm splint and sling. If it's displaced, then surgical reduction and pinning. And the complication can be compartment syndrome. Right, it usually occurs in children 2 to 7. High impact fall on an outstretched hand. The radiograph will show a fracture line and displacement of the humerus. In case of an occult fracture, inflammation surrounding the fracture displaces the synovial fat and appears as a wide anterior fat pad or absent and a posterior fat pad, which is normally absent. Right, next question. A 65-year-old woman after recent knee replacement surgery brought to the emergency with sudden onset severe headache, photophobia, and vomiting. She is confused and disoriented, and her GCS score is 12. Her blood pressure is elevated, and examination there's knuckle rigidity. Okay, so that could be subarachnoid hemorrhage. Her family informs you that she was on anticoagulation therapy post-surgery. Which anticoagulant was she most likely on? Pause. So the patient is most probably on rivaroxaban because post-orthopedic surgery like total knee replacements, patients are routinely placed on chemical thromboprophylaxis to prevent DVTs. Factor 10A inhibitors, this is an oral factor 10A inhibitor, are usually the main choice. So these are the questions for now. If you guys like my video, I'll make more. So do let me know.